Thank you, Eric. Thank you, Rich. And thank you for inviting me to speak about this important point. I think that the first question in reality is if a continuous therapy until progressive disease should always needed and feasible. We heard before that it is important to treat patients until progression, but in the trials, usually patients do not receive more than 6 courses of chemotherapy, and this is the same also in clinical practice. So we have to remember that metastatic colorectal cancer is a chronic disease, and patients spend 2 years, but usually during and after chemotherapy, that the side effects of chemotherapy can be very important. Think about neurotoxicity for oxaliplatin or asthenia and diarrhea for irinotecan, and that the continuous therapy, of course, has also an important heavy burden on the economic cost of the society. So, a global strategy during this period of treatment, patients can receive new agents, new regimens, ideally all the active treatments. They can have a drug rotation. They can have a rechallenge of the same agents or schedules. They can receive a surgery of liver or lung mets, and they can receive also local regional therapies. The purpose is, of course, to increase progression-free survival, overall survival, and to maintain or improve the quality of life. So in this long period, it should be useful for patients to deliver drug holidays or chemo vacation periods. We have to remember the definitions of what we are speaking about. A stop-and-go strategy is a strategy in which we stop all agents and restart therapy under progression. An on-off strategy is a strategy in which we give an intermittent administration of chemo, for example, 2 months on and 2 months off. A maintenance treatment, there was a discussion before, is a treatment in which we can stop an intensive schedule of chemotherapy, but we can go on with a decrease of intensity of chemotherapy plus or minus biologicals, or we can stop all the cytotoxic drugs and go on with biologics alone. So when we try an interpretation of the trials reported in the literature, we have to remember what is the difference according to these different strategies. Drug holidays. When to deliver drug holidays to our patients if it is needed or appropriate. We can do it at a predefined time, for example, after a fixed number of courses, 3, 4, 6, nobody knows. Or at the best response point, but not only considering the objective response, but also an improvement in PS and in quality of life, in remission of symptoms, and so on. We have to keep in mind that for our metastatic colorectal patients, the clinical benefit, the subjective effect of therapy can be very important. Of course, when patients request to stop therapy, for example, it is quite typical that in summertime, patients require not to go on with the treatment for 1 month or 2. And of course, we have to respect the willingness of our patients. Or after a long-standing, responding, or stable disease. But nobody knows what does it mean, a long-standing, 4, 6, even 12 months, and so on. Or probably other clinical or even biological criteria. The strategy of stop and go, it seems that in UK and in France it is very popular because there were some important trials according to this point. I can't go into details for the trials, but I will give you some remind of the trials. The first is the MRC CR06 trial, published in Lancet 10 years ago by Tim Morgan, in which after 12 weeks of chemotherapy based on 5-FU or on raltetrexate, there was a random because, between stop therapy and go on with the same therapy until progression. And as you know, the results were completely superimposable in the two groups. So in these patients, it was possible to stop therapy until, after a fixed period of time, until progression. Of course, the toxicity was lower when patients received an intermittent strategy of treatment. The French connection, the trial by de Ramon and his group, the Optimox, in this case the Optimox 2, because in Optimox 2 there is a period without chemotherapy, a chemo-free interval, and in this trial a completely new endpoint was designed. The problems of endpoints is very important when we try to interpret the results of this kind of trials. In this case was the duration of disease control, as reported here, and I'm sure you well know this. And in this trial, the results are here. So there was, in the maintenance arm, patients who continue to receive chemotherapy, a longer median activity of the therapy, and an increase in median progression-free survival, and also a trend toward an improved median overall survival. Of course, patients in the bad prognosis group had the worst results, and they, in these patients, could be a problem not to continue to administer chemotherapy. The other trials by the UK group was the COIN trial, in which there was a complex design. One of the points was a randomization between continuous versus intermittent therapy. And in this trial, the results were similar according to the strategy, even if this was observed chiefly at the 2-year survival. In this trial, another important point was the identification of some prognostic factors, and for example, one very important prognostic factor was the number of platelets. Patients with thrombocytosis did worse in comparison to patients without this parameter. So we can consider also the characteristics of the patients in order to define if that particular patient is suitable or not for an intermittent strategy. In Italy, we tried to define the so-called on-off strategy, the GERCOR trial, in which there was a randomization between a continuous treatment with FOLFIRI versus a treatment in which FOLFIRI was delivered 2 months on and 2 months off. The results are reported here, and the results are the same according to progression-free survival and overall survival, and toxicity was lower. Recently, very recently, at ASCO meeting, there was a meta-analysis made by the Ontario group because previous meta-analyses were not optimal, and the results in more than 4,000 patients were the same, no statistical or clinical significant difference between the continuous and intermittent strategies, and no difference according to the particular strategy or the particular regimen that was employed in this trial. So the discussion by the authors at ASCO was that most of these strategies had the same profile, 12 or 18 weeks of induction, a strict monitoring of patients, of course, and the reintroduction of therapy at the first symptoms or signs of disease progression. So this kind of strategy can be used in patients at the condition that they are followed very strictly and very well. Toxicity was lower in the groups receiving an intermittent treatment, chiefly according to the duration of treatment and the ability of patients to recover for the treatment. So the quality of life, when it was evaluated only in 2 of these trials, was better in patients receiving intermittent therapy. Maintenance. Maintenance was discussed before this morning, and many times maintenance is strictly related to a strategy of chemovacation. But in these trials, the main endpoint was maintenance. These trials were performed all over the world, as you know. Very quickly, the Optimox 1 trial, in which there was a period in which oxaliplatin was stopped, and in this trial, no difference according to the two arms. Also, the concept trial in US was a trial in which there was an intermittent strategy of oxaliplatin versus a continuous strategy of oxaliplatin, and the conclusions were in favor of an intermittent treatment. The macro trial was a trial performed in Spain, here in Spain, in which the real question was the comparison between the continuation of chemotherapy plus bevacizumab or bevacizumab alone. And from this trial, I hope you can see because I can't see very well here. And the conclusion of this trial was that the chemotherapy was not needed to maintain the response to the chemotherapy delivered before. Another trial, a phase 2 trial in Turkey, in which there was a decrease of intensity of chemotherapy because the maintenance was performed with capecitabine and bevacizumab, and no detrimental effect of not continuing oxaliplatin together with capecitabine and bevacizumab in the maintenance period. And the recent trials reported at ASCO, and one was discussed here before, the Dutch trial in which the maintenance treatment with capecitabine and bevacizumab was feasible, was able to prolong progression-free survival 1 and progression-free survival 2. And once again, it is very important to define the criteria of evaluation of this kind of strategy. And the trials for Switzerland reported before, in which I think it is very important the direct comparison between the continuation of bevacizumab alone and no anti-tumor treatment. The results, as discussed before, are not completely clear or convincing because the time to progression from randomization is in favor, but there is no difference according to the non-inferiority design of this trial, and the progression-free survival here in which is reported on the contrary as different. So the summary of the authors at ASCO were, as reported here, that non-inferiority could not be really and completely demonstrated, and of course this advantage reported in the trial needs to be balanced versus the higher treatment course, because these patients have to go on with the maintenance treatment with bevacizumab. I think, in my personal opinion, that bevacizumab can be an important choice for a maintenance treatment, but it is very important to consider all these trials altogether. Yesterday, I had the privilege here in this room to chair a session with a young medical oncologist, and our colleague from Denmark made a very interesting evaluation of these trials in the maintenance strategy. And I think that the most important point is that some patients might safely tolerate the treatment breaks, but they have to be a good prognosis. In particular, they have to be a normal platelet count at the baseline, normal CA after 3 months of therapy, and the induction period should be of at least 6 months. So the conclusion of my talk, on time, I suppose, is that a chemo holiday or maintenance schedule is important, but when we speak about the palliative setting, not for patients in which we have to perform, for example, secondary surgery after reduction of liver metastasis, and that a careful selection of these patients is very important because the data from the studies were not completely in the same direction, and we have to make a choice between our patients. I think in particular that the maintenance with a low-intensity chemo regimen, for example, deleting oxaliplatin and continuing with capecitabine plus bevacizumab, is important, but we should make a clear choice between our patients. The on-off strategy, which we evaluated in Italy, has a less clear role because, in my opinion, it should be better evaluated in other trials. I thank you for attention.